Wir brauchen noch beide das. Du bist ja gar nicht drin.
Okay.
Live auf YouTube.
Live auf YouTube as well. Hallo Gisela. Alles alte Bekannte.
Professor?
Yes.
We will switch off your sharing first in order to have the view of everybody there before we hand over to you.
Okay, thank you.
Wolfgang, ich schau mal, ob ich über YouTube reinkomme.
Mama, Gisela, macht mal euer Mikro aus.
Die sind nicht da. Du musst das tatsächlich von euch aus machen. Muss Lava vielleicht mal einfach das Mic ausstellen.
Ja. Okay. Ist ja egal, das wird ja nicht. Also, gut, jetzt können wir anfangen. Now we start. On behalf of the Nürnberger Initiative of Africa, I say Akwaba. That means welcome in the language of the Akan people in Ghana. Yeah, not here, but okay. So my name is Irit Holzheimer. I am member of the NIFA as well as, for example, Zimbabwe Network. And I welcome you all, and I'm quite happy to have two experts here, Professor Tinto from Burkina Faso, and I think you introduced yourself at the beginning of the speech, as well, Professor Dr. Haye Sib for Germany in Bremen. Okay, good.
Das Ganze wird live auf YouTube gemacht.
Okay. As you recognize, we talk in English. That is a compromise because Professor Tinto's mother tongue is French and other languages, and Professor Seb speaks German as well as other languages. And so we decided to do it in German. So if there is anybody who doesn't understand English or has problems, he or he has to raise the hand, and we will summarize it in German. But behind me, I know all people to understand English. Okay, that's all. You can ask the questions later on, also in German, and we will translate it. So a warm welcome again to Professor Tinto, and he will start with the speeches. Our meeting is called Health in Africa, the opportunities are in human resources. So we will learn about this, what does it mean, and we have an exchange between the North and the South. Okay, Professor Tinto, please start.
Thank you very much. Thank you, everyone. I hope that Larva will send me back the control of my screen.
He is the expert behind me. So what is there's no.
Let me try again to share the screen.
Okay.
Can you see my screen?
Yes.
Okay, thank you very much for this opportunity to really share with you my experience from the African perspective. My name is Halidou Tinto. I'm a pharmacist by background and medical scientist. I'm professor in parasitology working in Burkina Faso, where I am leading the clinical research unit of Nanoro, located at 85 kilometers from Ouagadougou. I'm really pleased today to share with you my perspective in terms of health in Africa. The success lies in the quality of African human resources. I will share with you my experience on malaria research because this is my main topic of interest. And for my presentation, I will first make a brief introduction on the context in Africa. And after that, I will follow with the introduction of the unit I created 10 years ago in Burkina Faso, that is called Clinical Research Unit of Nanoro. I will make a brief history of that creation and how the unit evolved until now, and I will end with the major achievement that we have been able to do since the creation of the unit. As you may know, Africa is bearing the highest burden of disease worldwide. And for many years, this was largely dominated by communicable disease. But with the epidemiological transition in the last 10 years, we clearly see a trend towards the non-communicable disease, including the hypertension, diabetes, and so on. But at the same time, Africa has been facing a high human resource for health crisis for many years. For instance, African host 40% of the world population, when with the 25% of global disease burden, when we have only 1.3% of global health workers. When you go in the area of research, you can see that this is worse, because as you can see on the figure on your right, you see clearly that Africa is lagging behind in terms of clinical trial conduct. You can see the blue line on the bottom here on the right side. But we all also know that the development of innovative interventions is needed for patient early access to new treatment and technology. I will go through and tell you why I decided to create this clinical research unit of Nanoro in Burkina Faso. I'm a pharmacist by background, and after my pharmacy degree, I spent some time in Denmark at the University of Denmark as a fellow to work on alternative treatment for malaria. After that, I moved to Belgium to do my PhD from 2003 to 2006. And after my PhD, I had the opportunity to either stay in Belgium and work as a postdoc, or move to the US, where I had a good proposition of job to work with the University of Ohio that was planning to second me in Papua New Guinea to lead a laboratory for malaria parasite culture. But instead of that, I decided to go back in Burkina Faso in 2007, when I created a new unit that is called Clinical Research Unit of Nanoro. But why I decided to focus my research on malaria? I find out at the end of my PhD that there were few places in Africa that have the necessary infrastructure and expertise to conduct clinical research at high standard level. I thought that young Africa researchers have the responsibility to fill this gap. And the second, why I decided to work on malaria, because as you may know, there is no malaria in Germany. There is no malaria anywhere in Europe or in the US. Without that, Africa people should take the leadership and the ownership for malaria research. I show here a map, the world map, where you can see in red the burden of malaria worldwide. And as you can see, Africa bears the highest burden with 600 million of people at risk, most of them coming from Africa, and over 200 million cases per year. And unfortunately, we record every year about 600,000 deaths, mainly children under 5 years. When you look at the economic impacts of the disease, you see clearly that this negatively impact on the economic of our countries. For instance, between 1980 and 1995, Africa lost about $74 billion because of malaria. Yeah, we can say we have some tools to fight malaria, including the bed nets, indoor spray, diagnostic and treatment of the cases, and new treatment. Despite all these tools, malaria is still killing, unfortunately, over 400,000 kids every year. This is too much. What could be the appropriate tools for the future? Without that, like many other epidemics worldwide, including the COVID-19, the vaccine is the most appropriate tool to really roll back malaria. We have seen clearly in the era of the COVID-19 that thanks to the vaccine, we were able to reduce the number of deaths related to COVID-19. We think that for malaria, we need the same tool, so we definitely need a malaria vaccine. That is why when I created the unit, I had the goal to generate scientific evidence and solutions to decrease the malaria burden in Africa. And I had the vision that in the coming 10 years, my unit will be one of the major research and training centers in Africa. But I can tell you it was not an easy task when I decided to create this unit after my PhD. Because when I came back in Burkina, I had a salary of about 450 euro per month, when my scholarship during my PhD period was 1,200 euro. So I couldn't get even my PhD scholarship when I get back in Burkina. But I decided to stay, and it was really, really very difficult because I started from scratch in a rural area with no electricity, no running water, no building, with a real modest budget. But I decided to really speed up and intensify the writing of projects to attract more funding to try to build a real capacity to face the challenges we have in Burkina Faso. And I was lucky, I could say, thanks to the Bill and Melinda Gates Foundation, I've got my first grants of 15 million US dollars, to really build my unit in 2007. And this funding was to test the first malaria vaccine that was called RTSS, developed by GSK in Belgium. If you have the opportunity to come and visit my center, you will see that we were able to provide today a well-equipped research platform in Africa, And I started with very few staff of 10 people. And I can tell you that today, the units employ 600 people working on 27 projects, not only on malaria, but also on other diseases, including cardiometabolic disease, nutrition, bacterial infections. So you can see that starting from malaria, we are now covering many, many other diseases. I will show you here a few achievements of our units. The first is our contribution to the development of new drugs, diagnostics, and strategies for disease control in Africa. Regarding the vaccine, as I said before, we participated to the development of the first malaria vaccine in Africa, and we are currently playing a key role in the development of the second generation of malaria vaccine. And last but not the least is our participation to the training of the next generation of African scientists, because I was able to launch the training of 25 PhDs within the last 10 years, which means every year I launch almost 2 PhD students. And these PhD students are trained everywhere in the world, including Belgium, Japan, Taiwan, France, across the world. And fortunately, so far, 10 people have defended their PhD, and I was lucky to see them all back in Burkina Faso, working with me at the unit. So we were able really to sort out the issue of brain drain, because many Africa scientists, when they have the opportunity to stay in Europe or the US, never come back. But I can understand, because the conditions are not very easy. For instance, as I told you, I had a salary of 450 euro when my scholarship was 1,200. This is really difficult, and you have to be convinced that you want to do something for your continent, to support the people that are staying in the continent, to really face all the challenges we are facing in Africa, to be able to come back. So you should go beyond the issue of finance or money. Okay, yes, the few results we are able to get through our vaccine trials. When we tested the first vaccine, this was a study conducted in 7 African countries, including Burkina Faso, where we tested the vaccine in 16,000 children of 2 age groups. And the vaccine showed an efficacy of 56% and over 12 months, and 36% of efficacy over 48 months. We can say that this is very modest, but as at that time there was no malaria vaccine, the WHO decided to move on with a pilot implementation of this vaccine across 3 countries, Kenya, Ghana, and Malawi. And the vaccine was able to show a reduction of about 30% of severe malaria. And based on that, the WHO recommended the use of this vaccine last year for a deployment at large scale in Africa. But as I said, this is really modest. That is why we decided with our partner of the University of Oxford in the UK to improve the RTS protein and produce the AR21, which is the new generation of malaria vaccine we are working on. This will be the second generation of the malaria vaccine. And I can tell you that we were really surprised to see, after 1 year of follow-up, after vaccinating children in Africa, in Burkina Faso, we were able to show a protective efficacy of 77%, almost 80%, which means that if you vaccinate 1,000 kids, you can prevent malaria in 800 of them, which is very important when we know that, for instance, in Burkina last year, we recorded 10 million of malaria cases with a population of 20 million. This is huge. By reducing these cases of malaria by 77%, I think this will make definitely a big impact in terms of public health, but also on the economy. What will be the next step with this new generation of malaria vaccine? We just launched in May a phase 3 trial that have the objective to really register and bring this vaccine on the market for the people. But in the meantime, learning from the COVID-19 experience, we don't want to wait too much. We want to move on, and hopefully next year, I am in discussion with our Minister of Health in Burkina Faso to see how we can start an implementation program of this new vaccine in Burkina in 2023. And I hope that this will happen. This is the end of my presentation, and I would like to end with these slides where the president of my country, the head of state, was so happy last year that we showed 77% of efficacy of the new vaccine we are testing. He decided to invite me at the State House with my team to congratulate us. Thank you very much for your attention, and I'm open for questions and discussion. Thank you. Over to you.
Thank you very much. It was very impressive. Okay, maybe we give you, Dr. Seed, the possibility to comment or to add something, or yes?
Sure, I can do that, and I think I'm on now, so I'm very impressed also with what you have shown, and I think it was very interesting to see the last slide also, where you showed the paper, and there were other papers as well. And it's always one of the core issues, or has been in the past, to discuss about authorship, who actually is on these important papers. And we have seen now examples, and that attest to the leadership that you have been able to take, that actually those people who are working on this, in this case Burkina, but probably many other countries as well, are in fact co-authors of this paper, because in the scientific world, this is really what counts a lot. So if you want to become as successful as Professor Tinte has become, I think the point is really very strongly made also, that they were able, and they have been pushing, and probably with his experience from the scientific world globally, he has seen how important it is to be there, to be a recognizable author, an author group. And that is, so the mechanism of science is really, it can be against the resources in less well-resourced countries, in the sense that those who have all the resources around them, they'd say US authors, European authors, they take over, you know, this part of the work in the end, and that is the visible part sometimes. And in your case, I think it has worked so well, and this is really recommendable for even your group, but even the wider, you know, African community of researchers, to really fight basically for fairness and for proper recognition. And authorship is one sort of visible aspect of this, and it's so important that you can really claim this is, you know, our work, and we are core at this point. And this is really also, when we now think about how could you get young people, the human resources of the future, into this kind of work, this is exactly what one needs to do then, to give them the opportunity to work on these big projects, to get visibility through that, to also just get excited with working with a team of good scientists globally, everywhere, but also including peers just around oneself, like Professor Tinte himself and his team can really demonstrate. So I'm here in Bremen, in northern Germany, also hot at present. But we also have some activities in global health. And just recently, last week, or 2 weeks ago, we had a delegation from University of Namibia here who came to us, and we have been having a small project with them where they come to us, visit us, and we go back to them later on in the year to discuss with them on the issues that are relevant for not only them, but also for us, because we are both having public health schools, we are running courses, we are running research, and we want to discuss on par really about, you know, what is needed on your side, what is needed on our side to improve things. And they were able to come with 6 persons, which was really nice. And there were young scientists also there who came along. And this was for me an example of what probably also motivates then, you know, not only us to, you know, integrate international global health in our teaching, but also for them then to say, okay, we know these people, we can collaborate with them, they give us ideas, we gave them ideas. And this is really what I want to make a strong point. We in the North can learn a lot from much of what is happening in the South, even on the academic level of organizing, for example, public health schools, focusing on local health problems, being very pragmatic sometimes about things that need to be done to get things running. We sometimes are very complicated here in the North, in Germany, and in the Europe in general. And this can sometimes be quite helpful to see, you know, are other people doing this? Mind you, I have also seen examples where they had nice procedures on the one side. On the other side, they said it's so complicated for us to do some simple things because there are lots of administrative issues involved as well. And I thought Germany is complicated, and they said, yeah, we are even more complicated in some parts of this. And so we could help there as well and say, look, let's make a joint plan how you might, for example, model your PhD approach to other approaches where things are less complicated for young people to actually reach their aims. So that they were taking up graciously, they were interested to see what could be done. So that was a nice experience from both sides, and we'll be able to carry on with them to discuss this further and to have more joint ideas. And so that is really important for the brain drain to collaborate, to make sure that people are also able to follow their ideas where they are, because as Professor Tinde rightly said, there are many local problems, and the local persons, the local academia also is actually, they're the experts for these problems much more than us from the North coming there and having some ideas how about things which may not be correct by any means. So we need to learn together. I think this is some very important teaching, and really the way that you said, we need to take even leadership in that particular problem of malaria, which really affects us, and we have all the problems at hand here. We have also pathways to solutions. That's the way how it should be. And I was also very impressed to hear that you're not only focusing on malaria, because that has been a discussion with our Namibian colleagues as well. There's more than infectious disease, unfortunately, now. We had Corona, which came across Africa as well, and very much across our continent here. But you face a problem of non-communicable disease epidemics, we can say, which we already have here, and they are now moving down to the south quite extensively, with cardiovascular disease coming in, cancers and neurological metabolic disease. All that is happening there, and so you will need even more health resources in the future. And perhaps I'll just move on a little bit to a few slides that I can show. Let me see if I can share my screen. Yes. But I want to be here somewhere. So these slides are in
the meantime, maybe I can react on.
Please go ahead. Yes.
Yeah, I think you pointed out the issue of a win-win collaboration between the Northern partner and Africa. This is very important because from my 20 years experience working in Africa and collaborating with Northern partners, sometimes the African partners' contribution is not valued at the level it should be. But I had a unique experience with the University of Oxford in our collaboration for the development of AR21, because this protein was synthesized in UK. But when it comes to write the paper and publish it, our partners in UK said clearly that yes, we synthesized the the protein, but you did the most difficult job, collecting data. And for the first time, I have never experienced this with our northern partner. For the first time, the University of Soto left us with the construction of the database, the data management. Everything has been done locally in Burkina Faso without an assistance or any northern partner. And this is something I want to raise to show that it's very important for us as Africans to really take the ownership of our research in Africa and not always waiting people to come from Europe and do things for us. When it comes to publish, he said clearly, you did the job and you deserve the position of last author as to show your leadership in this trial. And the first co-author are also an African author, who is one of my young scientists, Natama, we co-shared the first author with a young student from the UK. So it's just to confirm what you just said. In Africa, we really need a win-win collaboration with our northern partners. Over to you. Thank you.
Thank you. Now just going, so please.
May I interrupt you? Can you talk a little bit slowly?
Yes.
Because you are so fast, because you both are so interested in your issues.
I'm sorry. I'm sorry.
Told us, please say.
We are slowing down. Okay, so these slides, you see the slides, right? Hear it?
Yes.
Yes. So these are now in German, and I'm just going to widen up a little bit the discussion towards the global health governance and global health system. So what is actually the global health system? Many people, the states, state organizations, NGOs, but also private organizations and foundations. And Dr. Tinto mentioned the Bill and Melinda Gates Foundation. I'll come to this in a moment. So we have governance issues, and who is actually in charge of health globally is the WHO since 1948. Their budget, you see here, is $5.84 billion US. Is not a lot in comparison to budgets. For example, here in Bremen, our budget is much bigger, only in Bremen than the WHO. They have the World Health Assembly, an annual assembly of all health ministries, and they need to everybody has one vote there, which is quite nice. So small states have the same vote as, for example, the US or big states. And in some places it can happen that small states can actually put in, they have more voices, more votes than the big states. This is possible here. So what is important, I think, to realize who gives the money nowadays are really the big foundations, often enough. For example, the already mentioned Gates Foundation. Their actual annual budget is $3 billion US roughly. A lot of money, and this is coming every year. And you saw that the World Health Organization has $5.8 billion, but they run their WHO. They don't run studies like the ones that Professor Tinto mentioned. So what happens there? The whole place is, things are being reorganized, have been reorganized over the years. Much is now project-oriented instead of organized, even governmental coordination. So this is changing a lot. And one can ask, what is the legitimation actually? What is the legitimate, why are private or philanthropic organizations having the same level of influence in comparison to, for example, UN bodies like the WHO? And I was going to say a few words about this. This is what happened for the German speakers. You see here, we have been seeing during Corona a lot of problems, even weakening this international health governance even further. And we saw, for example, massive violations of the international health regulations, which is a core binding governance document. We saw that. But coming back to what Germany is now doing, there's for the first time, German researchers have come together to have a German Alliance for Global Health Research, really trying to partner with international partners mainly in Africa, but also in other countries in South America and Asia, and focusing the German health research a little bit. I'm jumping on this one. I just want to say, yeah, this is very important here. Already in 2015, when Ebola was a problem in not far away from Professor Tinto's home, it was said that robust national health systems, a strong 21st century WHO, these are international health regulation with strong compliance, and then the important thing comes in sustainable human and financial resources would transform the global health system. So das heißt, we need money and we need resources for running fair, strong, modern global health systems. So when we think about what do we have to change, actually, we need a stronger WHO, but we also need independence on that level. We need probably a lot more power from those state players, and the state players are also very important for health research in African countries, because WHO has a strong voice in many of the countries in the South. They have regional office, they have country offices, and often they are really the place to go to when you talk about who can support me when I want to build up institutional, for example, teaching or learning. So this is very important for also global health, and particularly also in Southern Africa. And we were talking, which really annoyed me a lot during this discussion on Corona. Really, we had the very obvious example of very unfair health or missing health equity across the world. And this was very obvious when we looked at the distribution of vaccinations, and the argument that often came when the discussion was on questions of the vaccine licenses, the vaccine, the licensing issues, and that the argument was made, well, we could do it, but for example, African countries will not be able to actually produce vaccines, to bring in the human resources to start the production process and the distribution processes. And that was a strong argument that was made. And it was, I think, without very good foundation, but it was definitely a protective argument. And now we have this situation that only very few places in Africa even know, 2.5 years after the corona pandemic has started, for example, are in a position to really have their own vaccine production. That's only, I think, 1 or 2 places. Maybe Professor Tinto can even say more about this. But the argument was very much a paternalistic argument to say it won't even help if we allow giving the licenses, but they will not be able to work and to make something out of these licenses. I really was quite angry about this argument, because as with you, I think we realize both that there is a lot of power and there are human resources that need to be developed clearly, but this is obvious. I want to jump on this one, because this was the COVAX initiative that helped in some ways, but certainly didn't help as strong as individual partnerships between countries. So what is needed, I think, when we move on to even your research and the distribution, for example, the implementation of malaria vaccination, we will have to strengthen also technology transfer. We will have to work jointly on understanding what is needed. Some of the technologies are there, but they need to be implemented and put into practice everywhere in the world, including African countries. And then once they are there, then you will be able also to work with them, but also from there on move on to develop own systems. But the initial technology transfer, like you had in your study, Oxford perhaps developed the proteins, but then the technology was transferred, the studies were done, production lines were established, distribution is now being discussed about. So these are all things that happen locally. And we need very strong local infrastructures for this. This is clearly some demand for the future, that this is definitely needed. And there's something which one can call decolonizing global health. So moving away from some colonial approach to what we just discussed, that the North or the West has, the intellectual power, and then this is kind of whatever is being done is being left to be distributed, and often unfairly distributed between the different partners. I was just going to say that Germany has been quite weak in responding to this. We have now our own strategy in Germany, which has these points that are written here: health system support, climate change to take into account, health promotion and disease prevention, health threats to reduce health threats, but also research and innovation. And there, definitely, this is the place where also support for human resources on the African continent come in. But it is anyway clear that if you look at all these issues there, for all of those targets and aims, you will definitely need local expertise. You will need local specialists, local health experts. And this is also something where we need to, as a civil society in Germany, be quite active to follow up on this German health strategy. And the question of, how can it be implemented and really assured that it is not I would say, colonial strategy. It has to be a decolonizing strategy, and also asking ourselves very much how we can support local structures, local experts, how we can make them also proud of what they can achieve, help them to really develop their full potential, and really, assist as partners and not as bosses of some kind. And it's just, this is the last slide, a nice paper that looked on equity and international collaborations. They tried to figure out what are the core dimensions that one needs to take into account. And we talked about what you see here, for example, authorship as an important point, but also sample ownership. We have seen many times that actually, for example, blood was taken in African populations or in other populations, and then it was transported to laboratories in the north to be stored there safely in biobanks or whatever. And actually then the samples were gone. And this is not possible anymore. They have to remain there where they are. The ownership has to be very clear. Maybe you have to transport some things for analysis, but it should be very clear who's the owner of this and where do they belong. And there are even international protocols. Nagoya Protocol, for example, is something that regulates this quite strongly, but it's a recent development. Then we have the research agreements that need to be fair, the focus on local health priorities we discussed already. The other point that I would like to say is trust. And the trust has not to be only from colleagues in Africa or South America to trust in us that we are honest and fair researchers, but also we from the North have to learn to trust colleagues like Professor Tinto to be able to do what they're doing and to be excellent in that. And this is really also highly important. And we are, I would say, often not too good. We have to learn jointly. But at the same time, it's also realistic that we have to acknowledge inequalities, because inequalities are there. There's more money, more resources, often in some countries, let's say here in Germany or elsewhere. And one shouldn't also just say, okay, we are all equal and we have the same opportunities. No, one has to be fair about that and open about that as well. And really speak about this, make sure what can the respective partner deliver in partnerships. And then I think this is what can be really an example of a success in the future. So I'm leaving it with that, and there's some resources here. I'm stopping my sharing, and I think we can move into discussions or questions.
Thank you very much. So then I give the chance to the audience to ask questions to both, I think. And yes, or some comments or whatever. I don't know how we do it, and this is Brian Salzfeuer.
Who has question? Okay, so there is a two-person first, you, and then yes, I'm Frank. I want to mention the problem of brain drain. So yesterday I spoke with some doctors from Berlin of the major hospital there, and they said 14 operations, 7 are cancelled because there's no personnel for help. I know now the embassy of Kenya, like my friends are neglected to have visa, cannot even stay. They block it. But if you are a nurse with professional experience, within 1 month you get visa to come here. In Mozambique, we have 4,000 doctors. In Italy, 400,000. But many doctors who are the best, they would quickly go. So I think you make PhD and to go for $450, this is like a madman. Somebody who is like a miracle and with so important consequences. But the reality is the other way around. And now with our problems in our health system, we will feel what we can. So some scientific people perhaps go to Africa, but brain drain is the other way around. And I think there's no policy to say if we get a nurse from Africa, if 3 nurses back, I don't know when. So please comment this problem of brain drain. You want to?
Thank you very much. So my question will go to Professor. I want to first by celebrating your courage and your success so far in malaria research in Africa. Moving from 1,200 euros as a student, starting with $400 is quite encouraging. For the success so far, I celebrate it. Then my problem is this, my question is this, about the vaccines for malaria. Each time I'm in Africa, I'm from Nigeria. Usually when I am exposed to mosquitoes, probably I got a place where I got a bite. Immediately I will start having malaria. But each time I'm not exposed to any such condition, I can stay for months without experiencing malaria. So I have heard about the first generation vaccine that was created, and I read sometime about how it progressed, but it was not encouraging. So in my view, I want to ask as a layman, innocently in it, is it better for us to probably go look more into the carrier of the malaria itself? Because when people are not exposed to it, based on my experience, they will not have it, or rather than developing the vaccine. Or how, I don't know how which one is more effective. I'm just trying to ask innocently. Because if you ask me, based on my own experience, I will probably look at this. I will focus my attention on the carrier of the malaria. Yes. Thank you very much.
By the way, I just want to inform that is a researcher from Nigeria. So it's probably to go back. So.
Excuse me, I didn't get the question very well. Can you repeat the last part of your question?
Okay, thank you very much. I will make it clearer now and short. The last part of my question is, based on my experience and what I've seen so far, I believe in my own local knowledge that probably you should ask me that I will focus more on the carrier of the malaria itself. Basically, I believe that the major problem of malaria in Africa is mosquito. So I don't know, because I'm aware also that the first generation did not succeed because of people kept on getting exposed to the carrier, and the malaria continued frequent. So I don't know if the second generation will address that, or which one should we focus on the vaccine, or probably we should focus on the carrier, how to solve the problem from the source.
Okay, thank you.
No question? Or...
Shall we start commenting, perhaps? Do you want to say something on the question of vaccines, plus other issues protecting against malaria?
Yes, thank you very much for your question. As I showed in my presentation, if you followed me very well, I listed a number of tools that are available to really fight malaria, including mosquito-treated bed nets to prevent mosquito biting. But despite all these tools, we still record million and million cases of malaria. It means that this is not enough. So instead of putting so money in these tools, maybe as we have seen with previous epidemics and global endemics, we think that the vaccine is the appropriate tools that was able to really sort out all the health problems, including the most recent COVID-19. That is why we think that malaria deserves the same strategy. And we are sure if we have a good vaccine, we will not need to use all the tools that are listed, because it would not make sense to continue to use them, because the vaccine can protect you. And the advantage with the vaccine is that if you are vaccinated, you are protected. But as you may know, it's difficult to convince people to use bed nets. Because if you see the design of our houses, sometimes in the villages, sometimes it's very difficult to hang the bed nets and use them. And coming to the drugs, as you may know, also we are facing drug resistance. And more recently, unfortunately, we hear that the resistance that occurred in Southwest Asia is coming slowly in Africa. And there are few countries like Uganda, Rwanda, where they reported some cases of resistance. This is the same with the mosquitoes. We are using insecticide to kill mosquitoes, but unfortunately, more and more mosquitoes are resistant to insecticide. So altogether, if you put all these difficulties, you will agree with me that the only way to really definitely roll back and sort out the issue of malaria is to have a good vaccine. And that is why we are focusing our efforts on that research. Over.
And perhaps I can say something towards the brain drain that you mentioned. And I think this is really a somewhat depressing topic, because unfortunately, I mean, if you had hopes for global health equity before Corona, and I showed the issue of the vaccines, these hopes have been somewhat smashed, I would say. It was a very good opportunity to show global solidarity, but basically we have not shown it, one must say. So, and the same issue now applies to the brain drain. And it was, you rightly said that, I mean, Professor Tinte is an excellent but rare example of what people decide on their own. But in general, the decision goes exactly the other way around, that people do tend to follow opportunities, money, quality of life, whatever, which they perhaps do not see where they earn very little money and then offers come in. And to resist those offers is one thing. But at the same time, what we can probably do is to really question systematically what are our health systems doing. We will, for example, here in Germany, we are also facing this issue now of, especially in the nursing sector, we are actually drawing well-educated nurses in very large numbers from Asian countries. In some of these situations, it's actually so that they already are training staff to be employed in other countries, which is somewhat unusual. I mean, so the Philippines, for example, they do this training, which is costly, and they know already these people will not work in our health system. They're training them to work elsewhere. And one wonders a bit about the logic behind it, but it is clearly so that we offer a large market and pay maybe in nursing not so very well, but better than in many other countries. So this is interesting. And for the doctors, the same story applies. This is really something where on a political level, probably on a policy level, we have to be a lot stricter and really define very clearly in what situations this may be permissible, let's say, to hire, large numbers of people from places where the resources are scarce. But this must be very, very restricted circumstances and not the general approach of running your own health system. And I've worked myself in the UK also, and I think I had no original British colleague. They were all from all over the world, but nobody was there from the UK. So that was quite a strange situation, but this is how they have been running their system as well. And again, even now they're also facing those problems. So to tackle that, it is nice if we have people like Professor Tinto who decide for various reasons, often altruistic reasons, to say, I'm doing this way, but the core decision and the most frequent decision is exactly the other way around. And we have to actually have some rules and regulations to stop that. I think this is the only way forward in this regard.
Yeah, I guess I want to react and share also my experience when I decided to come back in Burkina after my PhD. I wrote clearly a strategic development plan to tell when I want to be in 3 years' time, in 5 years and 10 years. And I say, okay, I will go back and try to set up what I have in mind. And I give myself 3 years to do that. If after 3 years, I'm not able really to do that, maybe I will go back in the US, because they kept my position open in the US for 3 years. Can you imagine? You say, we really need you, and we give you 3 years to make your decision. Anytime within the 3 years, if you want to come back and work with us, we are open to really give you the position. But I can understand those people who run away, because the context in Africa is very, very difficult. And if you want to prevent the brain drain, you run the risk to have the brain in the drain. That is another problem. So we have to be balanced. And as I said, you have to be really convinced to have a clear objectives and be really what we call in Africa resilience. You have to be really resilient to be able to have such success story as we have. And I always tell people that my proud today is not only building this unit and the number of PhD I was able to train, and seeing most of them coming back home to support what I am doing. This is really my proud. Over to you.
I just can add that I had a collaboration with the colleagues in Pakistan for, not so long ago. I was there, and I was really also impressed that the same thing happened. They had all excellent training from the US, from the UK, whatever, and the whole team that was there in Peshawar in northern Pakistan, they had all come back after their training. So something must have drawn them back, which is, their families, often opportunities that are offered. So what I think is a very good strategy is probably to think, what will make people with these capacities be interested in staying or coming back. And you probably need to offer local training to a good extent, and that's very important. And even Germany can probably help a lot. And at the same time, you need to offer, basically also incentives if people are elsewhere, that they basically also feel it is a good way to, bring in my expertise and go back to the places where I can perhaps even be more instrumental and effective in comparison to other places. But it's also easy to say this from a nice position here in Germany. So I can also really just feel along with those people who actually, for very basic reasons, maybe have to decide actually to go elsewhere because they have to take care of their families and earn money. And if this doesn't work, then at some stage you may have to take these decisions. There is no other way sometimes.
Okay. Thank you.
So there is a question.
Thank you very much. I would start by joining the voices that are congratulating Professor there in Burkina Faso for his very courageous decision. We praise such an act. Yes, and but I would now also like to touch on this of brain and a little bit on the side of the people who maybe have left their countries, because as we know, there are always several reasons for that, and to help the people maybe not to feel bad. I personally already had an experience of doing some training in a group which calls itself a diaspora group for their own country. And we got away with a very good lesson of the 3 T's, that one should not feel so guilty because they are all the 3. These are treasure, time, and talent. People who are motivated, when they have time, they can always go back to the mother countries and serve for a few weeks and be there on the ground. But when they have talent and they are aware, they can also nowadays with all this technology transport this challenge, have a connection with their people on the ground, and over exchanges also achieve something. And the treasure, as we know, everybody can always finance something at home when they have a heart for their country. So it's just to say, we don't want to make people who are away from home feel guilty. They have their reasons, but we know they can also move a lot. Yeah. And then just a little point on this global health, whatever this is called. Yeah, I really agree with the professor in Bremen that this was just learning with the lesson of COVID, a real bad example for the world. The rich countries started by getting all the vaccines for themselves, and there were so many millions of people dying in other countries. Everybody, I think, in this room has lost a loved one in this whole, which have not been the case, and that was really a shame. So I really hope that we go back to our senses, everybody, and make this global health to a real serious issue, so that we are not always just looking at ourselves. And in any case, in the field of health, we are not solving anything when we do that, because later the infections are coming. They are coming, you know, they don't know the border. So yeah, that is all.
More questions? Can I ask question from the last one? Okay, I have one let's say comment. I would like I'm Larva for organizing this event today, and I would like to address my comment to you, prominent Professor Pinto and Professor Dave, and ask you, today is an opportunity. You are meeting each other for the first time, I guess. And my question is, or comment is that seeing what you have talked about, yeah, Professor Dave, and the experience we saw with Professor Tinto, is that a possibility to create a kind of alliance, you as at the level of researcher or at this level, and to become advocates for this issue of encouraging people to stay home, or creating programs, or I don't know, but somehow to help to go beyond this difficulty. That will be my question to you. I want to say also that we have some researchers here from Nigeria, Burkina Faso, and there are normally in Burkina Faso or in Nigeria and other countries, yeah. And the question is, they are working in a program, a German program called Wasalna, I think, DAT, I think, and DAD, no? Yeah, and this kind of program is, I think, to encourage the people to stay home and to support this kind of project like Professor Tinto did. Might be a possible, let's say, possibility to let's say, the people to stay, not to go to let's say, to stop this brain drain. I don't know. What do you think about it?
Thank you. Thank you. I would like to react on what you just mentioned before my colleague can comment on that, to share my experience. I think when I presented, I mentioned it somewhere that I had a modest budget to start building the clinical research unit of NANORO. That modest budget was given by the Belgian corporation. I think this is a way how you can support people to go back home. When I finished my PhD and had this opportunity to do my postdoc in Belgium and in the US. And the US people were really interested. The director of the Institute of Tropical Medicine went to the Belgian corporation and said, look, we have trained this young African guy who published 8 papers within 4 years. He's very productive, and the US people are keen to really enroll him as a postdoc in their countries. We think that if we can support him with a modest budget to encourage him to go back home and try to build his own research group, that will be more useful. Otherwise, we'll put some money to train somebody to give to the Americans. This is frustrating for me as a director of the Institute. And it is in that way that they gave me a small budget, about 50,000 euro per year. I started with that to support me to go back home. I think in Germany, in the program you are talking about, they can do the same to see how the very talented students, the brilliant Africa student they have, they can support them with a modest budget to encourage them to go home and try to build something based on a clear strategic plan that these students can write and present. That is my contribution to this issue you just raised. And the second, about the COVID-19, the lack of solidarity during the COVID-19 era could be seen as a bad experience, but for me, this is a good opportunity for Africa to really wake up. Because we clearly see in the era of the COVID-19 that people in Europe first care about their people before caring about us, which is logical. So it's now the time for our politics, our government, to really wake up and take the ownership and the leadership of the disease control in our countries and not rely only on northern partners, because we have clearly seen in the COVID-19 era that if an epidemic like COVID comes, you try to protect your population first before thinking about other people. Just my comments. Over to you. Thank you.
I don't think I have a lot to say there. This is quite specific and correct what you're saying. I think it is also an opportunity because it has made kind of painfully clear, Corona, what is out there, and that when it sort of times get tough, then there is egoism rather than solidarity, unfortunately, which we would hope not to be the case, but it can happen. It's also not a regular occurrence, but in this case, definitely it was this way, and it will be a very good motivation to say, look, we need to develop our own resources. We need to train our own people so that they can take leadership and then, collaborate globally. And the colleague mentioned whether, global collaboration and bringing, building up allegiances is the way forward. And I truly believe that is so. And I mentioned this GLORA alliance here in Germany, which has at the core of this, of its objectives also to exactly do that and to strengthen collaboration, to strengthen the opportunities for researchers, everywhere, and less and low and middle income countries to advance really, and to really have make best use of available resources, maybe in the north and west again, and put them to such use that people in other countries can really benefit from them, and then work on joint collaborations on this par level of equal access to everything. That is the core idea, and I think it needs to be even further strengthened, which unfortunately negative side of things happens as well here. The DAAD that you mentioned, I mean, they have had serious cuts just now, so quite a lot of DAAD funded work will not be possible in the next years. This is due to the crisis that we have here, and money is not endlessly available, and we're seeing now that DAAD is actually losing out a lot of money in the next few years, which is really unfortunate for much of what we've been discussing here, because they have been providing good programs, and the idea to even, perhaps support excellent students to locally build up, research groups and so on is even better than just saying, okay, we have a project, that is much more sustainable even. So that will be something to take into account. And when I have opportunities to figure out what happens with our the global health strategy here, I will look at it quite carefully to see if such an approach is implementable and if the money could be shifted towards this direction. It's certainly interesting to find out. Yeah.
Are there any online questions?
Maybe people online? People online, do you have questions? Okay. Okay, then
Okay. Anybody else who has a question? There's the chance to ask them both. For me, maybe I have a question back to Impfung, was ich kann es nicht aussprechen. Have you had problems, Professor Tinto, when you went to the rural areas to vaccine the people, convince them? We have already had the issue, but how do you manage it? Because I can imagine that mothers say no, it's dangerous or whatever.
Okay, thank you very much. I went to this rural area because we worked with them before in the framework of the malaria drug resistance surveillance with the National Malaria Control Program. So I knew the village very well, but not only that, because also there is a private hospital based there, very well organized, where I had the opportunity to set up my unit. But I was also very strategic by engaging the community since the beginning of the unit building. For instance, we made some kind of gentle agreement that all jobs that are not professional, like cleaners, drivers, I will privilege the people from the village, so nobody will come from elsewhere to take these jobs. So by doing that, the village people feel themselves a part of your story, and they really honor your projects because they are part of that. All the field workers, for instance, so 1/3 of the staff are from the village. So this really facilitated the increase of the unit activities, because as I said, we started with 10 people and now we have 600 people working on various projects in all the regions. But I would like to come back on the political engagement also, because when I created the unit, one of the challenges was the electricity. There was no electricity, and because we are located at about 8,500 kilometers from the capital city. I went to talk with the chief of Nanoro to tell him that I would like to set up this unit, but a big limitation will be the electricity. How we can work together to convince the government to connect the village to the national grid of electricity. And he was so enthusiastic, and I was lucky that this chief was really charismatic, and he got in contact with the head of state, and we went to present the projects, and I tried to convince the head of state that there is no malaria vaccine worldwide, and this will be probably the first malaria vaccine to come on the market, and it's very important for Burkina Faso to be part of this success story. Without electricity, we'll not be able to do that. What can you do to connect us to the national grid? And he did it within 6 months. The village was connected. So if you have the argument to advocate, you can convince the political leaders really to engage in the initiatives you launch in the country. That is the experience I want to share with you, both with the community and also with the political leaders. Over.
Maybe just a comment on this. I think there will be more problems if the malaria vaccines are rolled out widely all communities who have not been involved in the studies and who don't know much about it. So there will be these fears, rumors, and whatever, which we have seen here and elsewhere, and also in African countries, quite common, quite some mistrust issues. So that will be an issue in rolling out and implementing once the vaccine has, is there for wide use. It will certainly have to be accompanied by very strong communication and information activities. Otherwise, it can be a perfect vaccine, but if it doesn't reach the population because they're afraid of whatever, one will have problems. So this is definitely an issue for the future and for maybe hopefully the near future when this vaccine is really ready to be distributed very widely.
Yeah, I'm sure you have the vaccine reluctance problem in Europe, but it was worse in Africa, where people were really reluctant to receive a COVID vaccine. But it's surprising that if you ask them if they will be ready to get malaria vaccine, they say yes automatically. Why? Because they don't see COVID-19 as a problem in Africa. They don't see people dying around them because of COVID-19. That is the problem, but they see every day the kids dying because of malaria. So the COVID-19 problem in Europe didn't have the same level of attention as in Africa, because in Africa, for many reasons, we were more resilient to COVID-19 disease. So the vaccine reluctance has also something to do with at what level the disease is a problem for the people. How do they see it as a problem? I don't know what do you think about that, but this is clearly a huge problem of deploying a vaccine in a country. If people don't feel that this is a problem, you will fail. If they think that this is a serious problem for us, they will adhere. I think that is the problem we have with the COVID vaccine, and we do not expect to have the same problem with the malaria vaccine. Over.
Hopefully. I have a question. Who produced the vaccine? Produces the vaccine? A malaria vaccine. So.
Who produces the vaccine? Is that the question?
Yeah. Okay. As you may know, we are very weak in terms of technology of vaccine productions, and fortunately, we have a collaboration with an Indian industry. We call it Serum Institute of India. It's a very big company producing vaccine, the API vaccine for Africa, and they have the capacity to produce 200 million doses per year. This is really huge, and we hope that this vaccine will be very cheap, simply because the money we use to do the research was given by the European Union, so it's a public money. All the project was funded by the European Union. So at the end of the day, the European Union does not expect to get a benefit. So it's like a subvention to support malaria research in Africa. That is why we are pretty sure that this vaccine will cost very, very low price and maybe more accessible for African people. So the vaccine will be produced in India.
Okay, thank you.
Yeah.
Are there any other questions? So we, as you can see, we sit here and it's really hot. Maybe you can imagine, and we have no ventilator here. So yes, are there any questions? The last call. You have one. Okay.
So in March, I was in Kenya and I met some Kenyans who work with GIZ, and they told me there is a paint for €6 and you can paint your house, and for half a year there are no insects and malaria inside. I have forgotten the name. Have you knowledge about this? Then in Kenya, my baby was vaccinated 2 times. We have to pay 50 euros. If not, no vaccine. And our baby had 6 times malaria. So it may help, but in the end, the doctors, they go away from Western Kenya, go to Nairobi, because it's not, otherwise the baby will have problems. But you give us a lot of hope, what you said now, that with India, there's a new generation of vaccine and accessible. But on the other side, health system is so corrupt. I doubt that when we have this corruption, then really people get access to this. But my question is this of these paints, and also what the colleague said, I think also the nets are very important. In Kenya, 50% have not the money to buy a net for 20 euros. No? Okay, thank you.
Okay, thank you. For this vaccine, we hope that like the other vaccines of the API, the vaccine will be free for the population. They will not need to pay any thing for that. And to assure you, we are planning in the next year pilot deployment of this new generation of vaccine in Burkina to give 1 million doses for free for the pilot implementation. So at the end of the day, this vaccine will be provided for free to the population, but of course somebody will pay the bill, and this will be the Gavi. The Gavi is the institution who currently pay the vaccine for the African children. So we do not have any worry about the accessibility of this vaccine. Thank you.
Do you want to say something about this alleged paint that helps? There's probably some pesticide, some pyrethroid or something in this direction that may or may not help, I guess, isn't it?
I heard about this paint that prevent mosquitoes to come in the houses, but they use insecticide, and we all know that with the resistance problem, it can be efficient or effective for some times, but we are sure we run the risk to get the resistance as we have got with previous insecticides, including bed nets. So we are really convinced that vaccine will be will be the best to really sort out definitely and eliminate and eradicate malaria in Africa.
Yes. Okay. If there are no questions anymore, I want to say thank you to you both, Professor Tinto and Professor Phil. There were a lot of information and a lot of ways what we could do that we have not in the near future, I don't believe this, but later on a better health system, a global health system, as you said, Professor said. And I hope that you would go do your way. It was really, I can't find the words what you are doing. And I hope as well, maybe you both find a way to communicate to each other. Maybe there is an alliance between you both. Hopefully, because you can, as we do this as well, and Professor said, learn from each other. And this is the result of this evening, so we are really proud of it. Maybe we will see us next year again, because at Akwaba, it's a bit different from these festivals we have. We want to have meetings to bring together the South and the North, and to have this discussions. And the last 2 years, even during Corona, we had always the issue on health, COVID in Africa, and so on. And maybe next year we have another issue on the health sector, and maybe we can invite you again. Thank you very much.
Thank you. Thank you very much.
Thanks. Bye-bye.
Maybe you want to give us, I have the floor, maybe if you want a last statement from you both.
No, I just want to say a few words to say thank you. This is a very nice experience of sharing experience, both Africa, Europe, and I hope that you will learn from my own experience for particularly the African people living in Germany. And I hope that also Hajo and yourself will advocate with the Germany government to set up some kind of re-entry grants for Africa, for brilliant African students, to help them and support them and encourage them to come back home with a modest budget to really fix them instead of leaving them running to the US or somewhere else. Thank you very much.
Thank you very much.
Yeah, I agree, and as I said, I will try and see what I can find out, and perhaps there are opportunities for that. But anyway, it's been a great experience to talk to you and with all of you here, to have some question and answer session. And these are big issues we are dealing with here. This is really something which will affect us. And mind you, we are having a hot climate. We have climate issues that affect all of us globally. It changes disease issues. It changes many other issues as well. And we are in that all together. And that will probably provide more need and more opportunity to collaborate. Which is the way forward. Thanks very much.
Thank you.
Goodbye. Have a nice evening.
Merci beaucoup, professeur. Je vous appelle après.
OK. Merci beaucoup. Allez, bonne soirée. Au revoir.
Au revoir.
Bonsoir. Bye bye.
Hast du die Adresse?
Kannst du mir sonst noch mal schicken, dann schreibe ich immer an. Ja. Okay.
Okay.
Ciao dann.
Tschüss, schönen Abend.